So we'll go through a few questions that I had written down for all the speakers, and then if we have time, I'll go through a couple of cases that I pulled together. But I think the one thing that was mentioned that I always reiterate to our residents is the first question I always ask a new peristomal hernia patient is, can you reverse the stoma? And I think that's just a really key thing because as Will, I think, mentioned, a lot of these patients will come in from rural hospitals where they're told you can never get your stoma reversed. And once they finally get here, our colorectal surgeons are more than willing to reverse the stomas. And I think when we've talked about recurrence rate in peristomal hernias, I think that's kind of the number one issue, is if you can get rid of the stoma, that's really key. I think the second thing is setting realistic expectations, which was mentioned in a couple of talks along the way. And so I describe these to the patients as the art of surgery much more than the science of surgery, because there's so many variables that you can't predict based off of their imaging and their past surgical history that will ultimately weigh into whether you can do a sugar baker or a keyhole. It's just very simple things because you don't know what the thickness of the mesentery is going to be. You don't know how much mobility on the colon there is or the bowel until you actually get in there and try to take a look at things. So I think setting realistic expectations for your patients, as far as we know these have a limited lifespan and will ultimately play in to what their recurrence rates are along the way. So I think it's really important. I guess my first question, Will, you talked about some of these things. When it comes to open repairs, what do you kind of worry the most about as far as risks with peristomal hernias in an open repair setting?
I think that the vast majority of times you're considering open repair. I think you're going to be doing a larger peristomal hernia with a large defect that you're going to worry about. Number one, can I get the actual defect of the hernia closed? How bad is the adhesion going to be, and how easily can I get this mesh in to, provide, not have a reoccurrence in 2 years or not have a high risk of recurrence. So I think that's part of the biggest thing I worry about is that what's it going to look like in the abdomen? Can I get the actual hernia defect closed, and can I get all the bowel reduced also too? Because I think a lot of times, I know in fellowship we worked on a couple of cases that sometimes it can be exceedingly hard to get that bowel out, especially from a midline approach, and sometimes you do have to do a double incision to get into the hernia sac and make sure everything is down, because the last thing you want to do is have something stuck up in there and slap a mesh on and have an obstruction early right there from something you couldn't really see or well from that standpoint.
I think that's a good point. Actually, one of the questions I had for Scott, like in lap repairs, sometimes it's going to be really hard to see inside the defect there to know that some of those loops are curled around in there. Any tricks for kind of making sure you have all the bowel out before you start closing them minimally invasively?
Yeah, I think that's a really good point. Many times you can't tell. Imaging sometimes can be helpful, particularly if there's not a lot of other intestine, but many times it's not well opacified. You don't have a sense, is it the adjacent bowel that's up there, or is it the stoma itself? And I think, although I prefer to close the defect, there's times, and in that video that I showed, I actually didn't close it because of concern of injuring that subcutaneous portion. So I think err on the side of caution when you're working in that portion of the abdominal wall.
And then Amy, when you talked about, kind of planning those different approaches and everything, I know one of the challenges we see a lot, especially in the APR patients, is the plastic surgeons come in and they're like, we're going to do a VRAM flap. And then all of a sudden, it's somebody who gets a pelvic exoneration and they have a VRAM and you need to bring 2 stomas up. So I guess in the setting of people with known complex abdomens, whether they've had a tram flap for breast cancer in the past or need a concomitant VRAM because of their pathology, any tricks for kind of picking stoma sites in those patients?
Yeah, I think one of the biggest considerations is what the patient can use, right? And so talking to them and making sure that you understand their lifestyle and what their body habitus is really one of the most important things. And again, having a wound and ostomy nurse be available. She is one of my partners in my practice. I mean, she's taking care of my patients right now, putting a wound back on what was a very similar abdomen that you showed earlier today. So I think in preparation for that, having extensive discussions with the patients about what their life is going to be like and how they can utilize it, because it's really about their quality of life and how they can use it. I mean, there's a number of studies that talking about how poor ostomies can really contribute to poor quality of life. And so understanding the patient, understanding their body habitus, and preparing for it as best as possible. And I think you had mentioned setting expectations earlier.
And then one other question for Eva. You talk about, kind of picking patients and who and does not need a surgery. And I guess if there's a common theme we've talked about today is that these will all come back. But do you tailor your approach as you think about these based off of potential recurrences down the road in your plan for who gets a repair? Anybody can answer that. Or...
I'm sorry. So my preferred plane to put the mesh in is also extraperitoneal. So I do it often like the sugar baker, but then in the abdominal wall, which is called a poly repair. But it's because I'm a hernia surgeon too, and that's my preferred plane to go. But if you salvage that plane, it's really difficult to do something else. And the difficult thing is always that when you're dissecting out the stoma loop from the parastomal hernia sac, I'm really afraid that will hurt the vascularization, that at the end of the procedure, the stoma will die. Because then you'll have a real problem, and then you'll get an infected mesh and everything. So yeah, it's something I take into account, but I always, like Will said, maybe you should start with a small procedure because it's gonna be there for life. You can also say you should start with the best procedure, so the recurrence rate is the lowest. So I go for, in my opinion, the best, but it's an invasive procedure doing a retromuscular TAR plane mesh, the poly repair. So yeah, and it's easy to do it after a sugar baker because that's interperitoneal, you can just leave that mesh in.
Great. All right, I've got a couple cases that I pulled in. We'll use the last 5-10 minutes to go through those, and we'll kind of ask the panel how they would manage them. These are my disclosures, and I think the most important one here is I actually just went through my last month of clinic to pull these cases up for you guys. All right, so the first case that I saw, and this one I'd really be curious kind of how people would manage. He's 25 years old. He had severe Crohn's disease, pretty advanced when he came in, had a total abdominal-colectomy and endoileostomy in 2017, which was a really complicated postoperative course. He had a massive PE DVT, had an open sternotomy and thrombectomy, and developed a parastomal hernia that I initially saw him for about 6 months ago. And at the time we went through that whole question is, can he be reversed? And at the end of the day, the general consensus was he's not a candidate for reversal. He's now having discomfort and pouching challenges. His BMI is 39. He struggled a lot with having a stoma as a young male unexpectedly. And so he's now left with what's going to be a permanent ileostomy at the age of 25 years old and morbid obesity. This is his picture, so you can see it's kind of not in an ideal location for him based off of some of the things that we learned earlier. And then here's what his CT scan looks like. There's all those great veins from his massive PE and secondary effects. So you can see not a huge fascial defect. He does have a kind of, you can make an argument of a concomitant midline hernia as well. And so first question, I'll leave it open. Would you fix it? I guess show of hands, who would fix it?
Today? Yeah.
In his current status?
No.
All right. Why is everybody else saying no?
If he's got Crohn's disease, he probably is not a candidate for a pouch.
He is not. We
Yeah,
tried a
so-
couple different surgeons just for hopes, and they all said no.
And it looks like you have enough of a rectal stump. Is it possible to just take him down and give him an ileorectal anastomosis?
Nobody wants to do that. None of our, he's literally seen 4 colorectal surgeons who all just said because his Crohn's was so advanced when he came in that they don't want to reverse him in any form.
Sounds like he needs to go to Michigan.
Yeah, no, great.
I'm at the VA.
I mean, I would say that I would fix it, but I think as the next part here is optimization. I mean, you get a little bit of weight loss from that standpoint. I think, as we talked about, it's not in a prime location, so this isn't for permanent. It needs to be fixed or moved. So, I mean, I think that, a little bit more weight loss, I think he would actually be a decent candidate to fix. I think it would be a big surgery, and just looking at the midline, it's covered. Looks like the bowel is going to be attached right on the midline as you go across, so he probably would have some pretty extensive adhesions, it looks like, on that scan.
I had a Crohn's patient as well who with a parastomal hernia. We actually had long discussions about having him undergo a sleeve before even considering a parastomal hernia repair. I think you just have to understand the extent of his Crohn's disease before offering something like that.
Yeah, his Crohn's is pretty well managed right now. So let's hypothetically say that we get him to lose some weight, whether that's medically or surgically. How many people on the panel would move his stoma at this setting?
I think off the information, yes.
Okay.
I guess it would. What does it look like when the stoma? Is it going to, if like you take the hernia down, is the stoma actually going to sit somewhere it was? But to me, it looks like, I guess, from it's off his line of sight, it's like hanging down from that. So, like it doesn't look like it meets those.
You probably can see the stoma.
Yeah.
It's very difficult to take care of.
I think I would personally do a lap sugar baker on him, and the reason I would do that is I think once you lose the weight, reduce the contents with weight loss, I think that skin is gonna collapse, and I think it's gonna move up. I personally use that as a last resort, moving stomas. I always try not to move stomas, so for me, stoma stays, I fix it, and then if he fails that, we could talk about something else.
How many people would fix the midline hernia at the same time? Perfect. This is very clear. And I kind of got a consensus based off of repairs. Some people would go extraperitoneal, some people would go intraperitoneal. I guess if you fix the midline hernia, would you run mesh over to the left side in anticipation of needing another stoma potentially and prophylactically reinforcing that side?
If I operated an ostomy open, you're always so close, like your ostomy opening, your fascial defect is so close to your midline, I always take it to the other side, so I do a retrorectus repair with your mesh spanning at the other rectus, and then I do the TAR plane to lateralize your mesh, lateralize your stoma.
Got it. All right, I'm gonna skip through to our third case here real quick, because we're running out of time. All right, this is another young male, also a history of Crohn's disease, but an even more complex history. Through several institutions, he had a total abdominal colectomy and ileostomy, then subsequently had a reversal of his ileostomy with a pouch creation and underwent an abdominal wall reconstruction, a TAR at that time, with lightweight polypropylene mesh. He then failed that due to horrific control of his bowel function, had a recreation of an endoileostomy, then developed a hernia that was revised locally for his endoileostomy, and he now has a recurrent and enlarging parastomal hernia. This is what his abdomen looks like, and this is his CT scan. You can see he's already had a stoma over there on the left side as well. All right, show of hands, who's gonna fix him? I mean, I think you're kind of obliged to. I mean, like, listen, nobody wants to go into it. Nobody wants to fix this guy, but he's 34 years old. He's going to have a stoma for the rest of his life. Like, there's really not a non-operative long-term management here. He's going to need an operation at some point. How many people would move the stoma based off of the CAT scan findings? Is that the first time that the entire panel has been in agreement on management? That's amazing. All right, so we're not moving the stoma. How many people would even venture? Will, you mentioned just put a scope in, give it a try. Is this a guy you'd put a scope in and see what you could do?
No, I feel like I'm sitting in the clinic in fellowship again having PTSD, but it is, I don't think there's any way it's, with all of the mesh in there and like wherever it looked like a loop coming up in the skin. I don't think it'd be doable, is what I would say, so, but that's just my opinion.
You can see that really big mesh spanning over the whole abdominal cavity. I would not go through that. You just kind of...
Not even try.
That mesh is extraperitoneal, right?
Yeah, it's extraperitoneal.
I would put a scope in him.
Yeah.
Just hope for just see where it looks like.
I would.
All right. And then, so let's say whether you can do it. So if you can get a scope in, Scott, what are you going to do? A lap sugar baker?
I would. That's what I would try in him.
Are you going to fix his bilateral inguinals at the same time?
No. Nope, minimalistic. I missed the inguinals on that.
They were pretty minimal. All right, let's say you need to open. Will, how are you going to fix them if you got to open?
I mean, I think the lap sugar baker, if you're in, is probably the best. I still think you'd have to do a sugar baker. You'd have to just come right through the mesh and then pull as much down. The one part that worries me is the bowel on the skin within the hernia defect, so it may have to be one of the ones you have to make an incision on the hernia itself to get it down. I'd probably just do a sugar baker from there.
So midline open sugar baker?
Yeah.
That's kind of what I'm leaning for, but maybe after today I'll put a scope in anyway.
I feel like as a colorectal surgeon, I'd really try to take him down first. Is there a reason for him not to have, again, an ileorectal anastomosis?
He was going to the bathroom like 50 times a day.
Before the
When he got his pouch the first
I
time.
probably would try to talk to the IBD doctors and see if we can optimize him medically and see what the rectal stump look like, as a first step.
Again, very clear. All right, well, we're out of time. I appreciate everybody getting up this morning and coming to hear all of our disasters and peristomal hernias, and have a great day.
Enjoyed your
Thank
talk.
you.
Very nice.
Thank you.